professional practice. We see this training as a bridge to support those learners transition from pre-service learning to independent professional practice. And then finally, a focus on interprofessional education, learning to learn as a member of an interprofessional team. And so these are three key facets of the STRIPE program that many of you are already familiar with. Over the last 18 months, AFREhealth and UCSF have developed several new training tools to be used on the STRIPE platform, including several modules on COVID-19, and one of these modules on COVID-19 and HIV has been widely used across the AFREhealth network. 26 universities, over 110 affiliated partners have used these training tools to improve knowledge and awareness and clinical confidence related to managing COVID. And over 1,500 learners have participated in COVID-19 related training, and over 100 facilitators have been trained on COVID related domains of practice. But let me, if I may, transition now to speaking about this new module, which broadly we have entitled COVID-19 Vaccine Hesitancy. In a moment, I'll be sharing more about the module, but before I do, I wanted to pause and acknowledge the profound inequity around vaccines. Right now, it's 6:15 in the morning in San Francisco in the US, very early in the morning, but one thing that you may be already aware of is the abundance of vaccines in the US, in San Francisco, while many Africans who are desperate to get vaccinated can't. I don't pretend to have an answer for that inequity. The vaccine apartheid, the vaccine inequity sits uncomfortably with me. I take consolation from the fact that there are brilliant, talented people across Africa who are motivating to get vaccines to those who need them. And I'm also reminded of this quote from one of my favorite theologians and novelists, Frederick Buechner. Here is the world, beautiful and terrible things will happen, don't be afraid. I can't whitewash or sugarcoat the vaccine inequities that exist, but hope nonetheless that this training module on vaccine hesitancy can ensure that as vaccines are available across sub-Saharan Africa, healthcare workers at your universities can be prepared to respond to those hesitations and concerns effectively. So let me now turn to asking the question, how commonplace is vaccine hesitancy? Is it a problem at all? Well, there have been two important studies that are worth highlighting for you. One was a study that was published by the African CDC a year ago, where they reviewed data from 15 countries. They surveyed a diverse population across those countries. And what is telling from the graph here is actually that vaccine hesitancy is not a huge problem. Across many of these countries, the vast majority of people surveyed were not vaccine hesitant. They are willing to get vaccinated. And I want to sort of draw attention to that. The second study is a newer study that was published in August of 2021 in the medical journal Nature, where scientists evaluated vaccine acceptance rates in a few key countries, and again found that the vast majority of people surveyed are not vaccine hesitant. They're willing to get vaccinated. These two studies, the first from Africa CDC and the one published in Nature, both suggest that vaccine hesitancy is not a major problem. However, things move fast in COVID times, and both these studies are quite old now. The first one over 12 months old. So to what extent is vaccine hesitancy a problem here and now across sub-Saharan Africa? Is it a problem that's on the rise? Well, even just this last week, there was an article published in a UK newspaper site suggesting that vaccine misinformation is spreading across countries, including Uganda. And the authors of this report in this UK website suggest that US conservatives are spreading vaccine misinformation to many Ugandans, suggesting, for example, that people should not get vaccinated because they have natural immunity and it doesn't make sense. Whether that's true or not, I think, you know, this is just one journalistic report, but suggests that maybe this is a bigger problem. More importantly, I draw your attention to this very eloquent editorial that was published in the Lancet paper. And hold on, I see that Roger has a question for me. Roger, did you want to ask a question? If not, I'll carry on. Well, the article in the Lancet, and I'd encourage all of you to find it, summarizes not the burden of vaccine hesitancy in Africa, but the drivers of vaccine hesitancy in Africa. And I quote here, due to a dearth of knowledge about vaccine facts, a history of colonial vaccine research abuse in Africa, and the duplicity of the global community, vaccine hesitancy is an increasing problem in sub-Saharan Africa. So I think, you know, with this information, I think we can conclude that anticipating and responding to vaccine hesitancy is an important agenda, or should be an important agenda for all of us. Finally, I want to highlight some research that comes from the Republic of South Africa. And this is data that our colleague from the University of KwaZulu-Natal, Dr. Musa Moshabela, presented to Stripe learners or Stripe audience several months ago, highlighting that across South Africa, in a survey that was performed there was a great heterogeneity of willingness to get vaccinated. And Prof. Moshabela, when he presented this study, highlighted that there was a marked unwillingness amongst participants in this survey in the Western Cape that was quite different from in other parts of South Africa, including Limpopo and the Northwest Province. But nonetheless, highlighting the fact that vaccine hesitancy in South Africa is an emerging problem. And perhaps if we have time, we can hear from some of our South African audience participants as to whether they recognize and acknowledge that in their setting. One of the other things that Prof. Moshabela presented, though, was that in that same survey from South Africa, the most important group within society for addressing that vaccine hesitancy were doctors and nurses. And this study presents how favorably different members of communities were to receiving information about vaccine hesitancy. And you can clearly see on this slide that nurses and doctors were regarded as the most trusted members of society with regards to providing advice around vaccines. And I think a key conclusion here is that healthcare workers need to be informed to address concerns
Alors, vous m'excusez infiniment. J'avais beaucoup de problèmes ici, un grand problème ici. Je n'ai pas pu prendre ce qu'il parlait. Mais c'est un sondage. C'est un sondage qu'ils ont fait en Amérique. Et c'est le résultat des
rising problem of vaccine hesitancy that may become a bigger problem in sub-Saharan Africa as vaccines become more widely available. I have just one last slide here, and then I will pass over to my colleague, Dr. Dadosovich. And I want to end where I started by highlighting for you that for most Africans, vaccine inequity, lack of access to vaccines, rather than vaccine hesitancy, is the major problem right now. This is data that I took from the Africa CDC website 2 days ago, highlighting that across Africa, only 11% of people have been vaccinated, fully vaccinated, received at least 2 doses. Whilst South Africa has vaccinated 28% of people, the numbers of eligible people vaccinated in other countries are much, much lower, according to Africa CDC, with only 2.7% of eligible people vaccinated in Nigeria, 3.5% in Ethiopia, under 4% in Uganda, and just over 10% in Kenya. However, and this is where I'll end, as vaccine access increases, it is critical that healthcare workers are able to respond to concerns and questions of their patients. And so in that context, we hope that this module, this new Stripe module on vaccines, will be useful to you. And so now I'm going to hand over to my colleague, Dr. Rand Dadosovich, who is going to walk you through the module on the website and explain the different components of the training module so that you can then use it with your learners at your institution. So I'm going to hand over to Dr. Dadosovich now, and then I'll be available after he has reviewed the module with you. Rand, over to you.
Great. Thank you so much, Mike. Good afternoon, good evening, everyone. Thank you again for joining us. We're very excited to share our module on kind of COVID-19 vaccine basics and vaccine hesitancy. So let me share my screen. Okay, I trust you can all see this. So I've logged into the Stripe platform here on AFREhealth, and this is what learners will see. So they'll navigate to module number 19. And again, the title is COVID-19 Vaccines and Vaccine Hesitancy. So first, I want to go through just a roadmap of what the module will look like to learners. So this is case-based, and the learners will meet Amara and kind of follow her on her journey in navigating COVID-19 vaccines in the healthcare setting. So here's a roadmap for the learners. Learners will be presented with a pre-knowledge quiz that they should complete before embarking on the module. They'll then navigate to an interactive self-paced module. There's some opportunities for discussion and role play and facilitation via Zoom, and there are links to facilitator handouts within the module as well. And then finally, they'll complete with a post-knowledge quiz. So as you can see, as we scroll down, there's a link here to the pre-knowledge quiz, and then the online module link is here, and I'll click on that. So as a reminder, this is the interactive self-paced module. So if we click on this, learners can enter the module, and you can actually make the screen slightly larger by clicking on this button here. So let me navigate to the beginning. Okay, so you can see an outline of the course by clicking on the details button. And then I wanted to walk through each of the sections to give you a sense of what the learners will be encountering and to take you through our objectives and goals. So the overall goal of this session is to review the major classes of COVID-19 vaccines, their common side effects and risks, and to discuss strategies for identifying and navigating vaccine hesitancy in the clinical environment. Okay, so our learning objectives, there are many. This is an action-packed module. So one is to differentiate between the major classes of COVID-19 vaccines. Two is to review the data around vaccine efficacy. And again, this is speaking to the idea that Dr. Reid was just talking to, which is that we really want to equip healthcare workers throughout sub-Saharan Africa with the tools and the information around vaccines to be able to appropriately counsel patients and community members who may be facing vaccine hesitancy. Three is to identify the most common side effects, contraindications, and risks of COVID-19 vaccines. Four, to review vaccine recommendations for different groups, including people living with HIV, pregnant women, and those with a history of prior COVID-19. Five, to discuss the major barriers to equitable COVID-19 vaccine dissemination. Six, to discuss factors that may contribute to vaccine hesitancy among patients, their families, and communities. And finally, to apply the principles of motivational interviewing to engage vaccine hesitant patients and other persons in conversations about vaccination. So as I scroll down, I want to walk you through the first subsection, which is really the basics about COVID-19 vaccines. We start with a case. So Amara, she's 27. She presents to your clinic with her 5-year-old son for a well child check. She's heard about cases of COVID-19 in the neighboring town, and she wants to know if there's anything she can take to prevent infection. So we walk through some of the basics around COVID-19 vaccines, and in particular, the major classes of vaccines. And learners can hover over each of these icons to learn more about the different types of vaccines. And let me see where this popped up, one second. Okay, so if I hovered over the nucleic acid vaccines, and this gives information around those types of vaccines, and of course, mRNA vaccines are one of the available COVID-19 vaccines. So as learners move on, we provide a table of the currently approved vaccines, and this table is a summary of the most common vaccines used throughout Africa that have been approved through emergency use listing by the WHO. It lists the vaccine name, the vaccine type, the recommended dosing schedule, and the approved ages. One thing we try to emphasize in the module, and that's important to share with learners, is that this information is fluid and obviously dynamic, so it is subject to change, and we really want learners to be deferring to country-specific guidance and the most recent WHO guidelines as they're completing this module, because this information may change. Learners are then presented with a brief activity in which they're asked to kind of assign the vaccine name to the type of vaccine it is. And again, this is just trying to cement some of the learning from this table. And then we have a multiple choice question, just asking about which vaccines have been approved by the WHO for people in the age range of 12 to 18. So if I go ahead and answer that, you'll see that that takes me to the end of the question. Okay, moving on to lesson 3. So we return to our case. You're the healthcare worker, you tell Amara that she's eligible for the vaccines and that you do recommend vaccination. She says she's heard that people who get vaccinated are still getting sick. And she wonders why she should get vaccinated if it won't stop her from getting sick. So in this section of the module, we really wanted to address the different aspects of vaccine efficacy. And so we take learners through several elements of vaccine efficacy. The first being protection and timing, knowing that the full efficacy of vaccination occurs around 2 weeks after completion of the injection. We walk through protection and infection and how the COVID-19 vaccines are very effective at preventing severe disease and hospitalization, but that breakthrough infections can occur and that people may still develop mild symptoms despite having been vaccinated. And then we talk about protection and transmission. So we know that people who've been successfully vaccinated against COVID-19 are less likely to transmit the virus to others, but its main benefit is, of course, preventing severe illness and disease. There's a section just to describe the distinction between efficacy and effectiveness. Again, efficacy refers to a measure of how much the vaccine lowers the risk of getting sick, and it's usually measured in a controlled clinical trial, whereas effectiveness rather, describes kind of the real world measurement of how well the vaccines work. And we do address variants and how as new variants emerge, this is changing some of the initial data around efficacy and effectiveness of the vaccines. Moving on, there's an activity for learners to think about the issue of vaccines and hospitalization. And there's a multiple choice question before that. And so we present learners with a graph here, which is summarizing the hospitalization rate in the United States for a 6-month period last year among those who are vaccinated in green compared to those unvaccinated in blue. And this graph really highlights the benefits of vaccination in preventing hospitalization. We then move on and look at the issue of the COVID-19 household attack rate, or how likely is it that someone who's infected with COVID-19 will go on to transmit that to people with whom they share a household. So we have learners examine a graph, and this table is from a study in the New England Journal of Medicine, which is looking at the vaccination status of index patients. So on the left, those who are not vaccinated compared to those vaccinated with the AstraZeneca vaccine and one of the mRNA vaccines, and then looking at household contacts, and among those household contacts, how many went on to develop COVID-19. And there's a large benefit in reducing the risk of COVID-19 based on the vaccination status of the index patient. So we're asking learners to interpret this graph and then answer a question based on this table.
Nous vous demandons d'interpréter cette graphique et rentrer ces questions, remplir les questions.
Okay, Lord Michael, I am hearing your interpretation now, so I'm not sure if you pressed a button, but thank you for interpreting. So moving on to lesson 4, this is COVID-19 vaccine side effects.
Donc, pour continuer.
Again, we're identifying the most common side effects, contraindications, and risks of COVID-19 vaccines. So back to our case, after discussing the benefits of vaccination, Amara does choose to move forward with vaccination, and she asks whether she should anticipate any side effects. So in this section, we review the most common side effects, which are generally mild and include low-grade fever, chills, and myalgias. We do address the rare incidence of more serious side effects, but still vaccination is strongly recommended for eligible individuals. And some of the vaccines, as you all know, are associated with severe allergic reaction like anaphylaxis, which is why for certain vaccines like the mRNA vaccines, it is recommended to monitor patients for a short period of time after vaccine administration. And then learners are asked to sort a few prompts into a true-false buckets. And this again is addressing some of the common myths about COVID-19 vaccination. So as I'm sorting, you'll see it gives me a prompt that's correct, that COVID-19 vaccines are not associated with infertility. They cannot give you COVID-19. You may develop low-grade fever, chills, and myalgias, and you may have pain at the vaccine injection site. Okay, this section ends with some information about the contraindications to vaccination for COVID-19. So again, there are not very many strict contraindications. Currently, the only contraindications are a known history of anaphylaxis to vaccine components, which may be managed with in the right healthcare setting or with the help of an allergist. And then currently no vaccines are approved globally for children younger than 5 years old. Okay, moving on to the next section of the module, we're reviewing vaccine recommendations, and specifically for different groups like those living with HIV, pregnant women, and those who have already been infected with COVID-19. So Amara returns to the clinic 1 month later with her 16-year-old sister. Her sister had COVID-19 3 months ago and asks if she should still be vaccinated. And so we take the learners through a series of questions, true, false statements. And in this case, it's asking if patients with a history of COVID-19 don't require vaccination. That is false. So vaccination is recommended even with a prior history of COVID-19. And then we share some information about vaccination in HIV, including the strong recommendation for people living with HIV to get COVID-19 vaccines, given that it does decrease the risk of severe outcome. And that there's a strong recommendation for people who are pregnant, women who are pregnant, to get the COVID-19 vaccination. And we linked to some information from the American College of Obstetricians and Gynecologists. This is also recommended by the WHO. And several large studies have demonstrated the safety of COVID-19 vaccines in pregnancy. Okay, so just 2 sections left to walk through. This section, we wanted to address the major barriers to equitable COVID-19 vaccine dissemination, and Dr. Reid addressed this in his opening remarks, but we know that this is a huge challenge for low and middle income countries. And so we really wanted learners to be able to discuss this in small groups. And so this section is really designed for the Zoom component of the module, but we also wanted learners to have an opportunity on their own as they're reviewing this material independently to start thinking about what they've seen in their communities and what they've experienced, and to describe in a few sentences some of the barriers that they've seen to vaccine dissemination. So there's an opportunity to enter that as a free text answer here. Okay. And then they submit their answer, and then we just remind learners that we'll revisit this during the Zoom session. There is an infographic here thinking about some of the barriers to global vaccine dissemination, both at the individual level and then of course at the national and global level as well. And we hope that this prompts a rich kind of multidisciplinary discussion among learners. Okay, and then the final section of our lesson is addressing the idea of vaccine hesitancy and really giving healthcare workers the tools to navigate vaccine hesitancy in the clinical setting. So we again return to the case. You do recommend that Amara's sister be vaccinated, and then you learn that their younger brother is hesitant to be vaccinated due to concerns about side effects. And so we ask learners to think about the concept of vaccine hesitancy and to address or to identify factors that they believe contribute to vaccine hesitancy. And these include misinformation about vaccines, concerns about side effects, and lack of confidence in vaccine effectiveness. And as you can see in our module, we've really tried to give healthcare workers the tools, the information to address all of these concerns. And then finally, we introduce the principles of motivational interviewing, which is a patient-centered tool to really address patients who may be vaccine hesitant or who are struggling with other difficult decisions. And we introduce the framework of the 5 A's, and this is one of the tenets of motivational interviewing, really centered around healthcare workers engaging patients and other persons who may be struggling with difficult decisions. The tools for healthcare workers center around the 5 A's. So asking, advising in an empathetic manner, assessing the patient's or person's readiness to change their behavior, assisting the patient with changing the behavior, and then arranging follow-up, including additional counseling and support. So this is a framework that we help healthcare workers can then bring to counseling patients who may be vaccine hesitant. And again, we've asked learners to practice in a free text response what they might say to Amara's brother, who is expressing some hesitancy around COVID-19 vaccination. So how they might apply the 5 A's model in this scenario. And we also hope that learners will revisit this question during a breakout session on Zoom and be able to practice in a role play actually applying these tools in counseling a patient who may be vaccine hesitant. And to wrap up the module, we have linked to some high quality fact sheets and other information for learners. There's a great resource that the WHO has put out about a helpful framework in discussing vaccines with patients, and we've linked to that here. And then more information from the WHO, including the most up-to-date information about the currently authorized vaccines and information about the groups that are eligible for vaccination. So that concludes a walkthrough of the module. I'm happy to pause here. I know that was a lot of information. Take any questions or any comments.
Yeah, thanks, Rand. Both Rand and I are available if there are any questions, either about the module or when it will be available. Please don't hesitate to add those questions to the chat or come off mute and we'll answer them.
Like, there is a question from Priska. Is advising acceptable in counseling?
I'm not sure I understand the question, but I think it probably, the extent to which an individual can provide advice, should match their role on the care team. Certainly, this module does not speak to the specific roles vis-a-vis who should be advising on what different elements, but Priska, let me know if you want to clarify what you meant there.
Okay, and then a very good question. When will the module be available for learners?
Yeah, great. My colleague Cheyenne, do you want to speak to that? Cheyenne is the program manager for Stripe. I think she has some insights here.
Yes.
Do you want me to clarify my question, or it's fine?
Why don't we do this? Let's have Cheyenne speak, and Priska, then I'd love to hear your question. Thank you.
Oh, thank you. The question has been read. We're told when you are counseling, one element you must avoid is advising. So one of the 5 A's that was mentioned not too long ago include advice. That's why I wanted to get that clarification. If it's
Okay,
proper to advise. Thank you. Over.
Okay, thanks, Priska. Rand, do you want to jump in and then Cheyenne?
Yeah, I would say that, this is just a framework. And so I think healthcare workers, depending on their role in the healthcare team and, the context of the individual encounter with the client or the patient, has to really use their own judgment and apply what feels right for that decision. So in the decision around vaccine hesitancy, if the healthcare workers have the tools and the background to be giving advice or advising patients, then I do think it is appropriate. Again, there is a strong recommendation for many people to receive the COVID-19 vaccines. And we know that being explicit and very clear with patients does lead to acceptance of vaccines. So for example, if a physician or a nurse or other healthcare worker says very clearly, I strongly recommend that you get the COVID-19 vaccine, we know that that has a strong impact and actually increases the likelihood of vaccine uptake and acceptance. But I think it must be applied in the individual context of the healthcare worker and in the client.
Thanks, Rand. So for the question on when the module will be available, so AFREhealth is currently working with 4 schools right now to pilot COVID training. What Rand just presented will be available to 2 of the schools in Anglophone Africa. And then thereafter, AFREhealth will work with UCSF to offer AFREhealth members the chance to sign up for the course and take the course together. And it'll be facilitated by a combination of UCSF and AFREhealth faculty. As far as when, so the school selected for piloting the modules will begin in March. Marietjie or Georgina, if you would like to state the timeline for others, please do so.
Well, we hope as soon as possible. We won't go through a full pilot process. We will make it available as early as possible. But we will let all AFREhealth members know. Shahan, here's another question for you. What is the approximate time to complete the module? And can one save progress as one goes on?
I'm curious if there's anyone on the call who's familiar with our earlier Stripe modules and who took them. My estimate from personally going through would be about a half hour, 30 minutes. And yes, you can, if you need to, if your session is interrupted, you can leave the module and then go back and resume.
Thank you. There's another question before that. What if a client is hesitant due to religious reasons? Any way forward? Michael Rand.
So we don't explicitly address religious perspectives in the module, except to say that I think these tools for motivational interviewing can help play a role in identifying or helping individuals identify what are their motives for not getting vaccinated. And I think we're keen to assert that there is no, the module, it does not focus on pressuring people to take the vaccine, but help them identify their own internal motivations once they've understood the science. And as you know, Marietjie, I don't know that there are many religions that are, none of the mainstream religions are advocating not taking the vaccine. And I think as individuals understand its safety, its efficacy, its protective effect, then some of those religious motivations dissolve away. But certainly the goal of this is not to persuade people who have strong religious perspectives to take the vaccine per se. I hope that answers the question.
Okay, Mike, there was a question around the 5 A's. I think that has been addressed. Rand has posted a link, but the 5 A's, like Mike says, is part of the whole motivational interviewing approach. And I know there are courses being presented on motivational interviewing as a tool in health professions, service delivery. So somebody's asking about the slides for today's presentation. Maybe Roger, what is your plan website-wise and distributing the slides and the recording?
Yes, so this will be uploaded on the website with the video and the slides as well, and then the link will be shared with the participants in here.
Right, can you just put the AFREhealth website link in the chat box?
Okay, let me do that.
Okay, Roger, the Francophones, are they still getting how do they get a chance to ask a question?
Okay, so I have asked the interpreter to ask them to send in their questions in the chat box so that he can then read it to the speaker when they are done. I mean, when everything is done. But I'll switch back and then find out from my colleagues to see whether there are any questions. I'm sure he can hear us at the moment. Yeah, he can still hear us at the moment, so he will ask.
Oh, okay, good, great. So there's a longish question. Lack of access and hesitancy are entangled problems and they feed into each other, and going about exploring hesitancy in settings where there is no access could be counterproductive. We just scroll down.
Now, I'll respond to that. I think we acknowledge that, you know, and I said this at the beginning, that the lack of vaccine access clearly has a bearing on how and when these trainings are relevant. However, to be clear, the module is focused on healthcare workers, not on the public. And we do think it's the responsibility of all healthcare workers to be informed about the best science, so that they can deliver informed, patient-centered, compassionate care to all clients. And so our hope is that by equipping clinicians, frontline clinicians, whether you're a nurse, a doctor, a pharmacist, with this information that Rand outlined, will help you, or your learners will help your learners to be able to address those concerns. We are not making any recommendations around when and how this should be used with respect to when vaccines are available in your setting. But regardless of when vaccines are available in your setting, as a healthcare worker, we think there's a responsibility to understand the best science and to apply it appropriately. And that's the goal of this module. I hope that makes sense. It's a great question from Nada.
Yes, at this point, I just want to say that we do have an evaluation form for this webinar, like all our webinars. Roger will chat it before we close, and please, we would really like you to complete that. Mike, just want to ask you the question that we are finding in South Africa as the vaccine rates increase and you're going and the wave decreases. There is a vaccine apathy as opposed to hesitancy. How is there a different approach between the two, the apathy versus the hesitancy?
I don't know the science here. I wonder if Rand does. I suspect some of the tools that one might employ would be slightly different in terms of understanding the motivations that are preventing somebody from getting vaccinated. But the utility of motivational interviewing as a means of communicating with clients probably is the same, regardless of whether somebody's motivation to not get vaccinated is due to apathy, as compared to due to some concern or diffidence about the vaccine. So I'm not sure whether that quite answers your question. Very insightful question there. I would also say, and Dr. Moshabela presented this in his presentation back in October, the fact that there is a small and diminishing proportion of South Africans that are not getting vaccinated is consistent with theories of change more generally. Dr. Moshabela used the theory of diffusion of innovation to highlight that there'll always be some proportion of the population that is resistant to change or innovation, in this case, vaccines. And being responsive to the fact that community will always exist, but requires tailored, patient-centered solutions is critical to how we address the challenges of vaccine hesitancy.
Right, thank you, Mike. It's maybe also as the percentage of those who are already vaccinated increases, these other relative low percentages just become sort of more visible. Roger, I'm just curious about our Francophone participants, questions from them.
Currently, the interpreter can hear you, so
He can hear me?
yeah, he can
Lord
hear
Michael?
you. Lord, you can switch to English to speak to Marietjie.
In the meantime, I'm going to read what Ruth says. She says, thank you very much, team, for the well-articulated presentation. We are motivated as health workers to have the tool that will facilitate our teaching. Great, thank you, Ruth.
Thank you for reading my my comments. Thanks very much.
Great. It seems that we are up to the hour, and I don't hear Lord Michael saying something. I just want to thank the interpreter. There was a short break in his presentation. He was lost due to connectivity, but he picked up again. And Lord Michael, please now ask all our friends, participants, to give us their feedback, either on the evaluation form or a direct email to Roger or anyone at AFREhealth about how this worked, because if this worked well, it's really a model we want to continue going forward. Then thank you so much, Mike and Rand, for your presentations. It really looks like a lovely, simple but informative module. And I myself are very keen to do this as soon as it becomes available, and we will work very hard to make it more available. Elsie, do you want to say a last word from AFREhealth?
Hello.
Yeah, just to thank you, Marietjie. Thank you very much for moderating, and Mike and Rad, we are so grateful for this. I must say, like Marietjie says, it's very interesting, and I love this way of learning and teaching. So I'm hoping that many AFREhealth will take this up and use it. Thank you very much, our UCSF partners and the whole of the AFREhealth community that has attended.
Thank you so much. Thank you so much, Elsie. And I want to recognize our president, Professor Abigail Kazembe, who also attended. Thank you very much, Abigail. If I may ask if Roger and Lord Michael can stay behind for a few minutes when we're done here.
Okay.
Thank you, everybody. Aisha says, brilliant presentation. Thank you, everybody.